Hello, and welcome to Inspire Health's Author Spotlight podcast. I'm Jim Edwards, the publisher at Inspire Health, and today I'm excited to introduce a very special guest, Dr. April Bigelow. Hi, April.
Hi.
Dr. Bigelow is a clinical associate professor from the University of Michigan School of Nursing, and she's the author of our upcoming book, Survivorship: Living Well During and After Cancer. Dr. Bigelow is not just an accomplished academic and educator, but also a source of profound inspiration. Her commitment to making learning accessible to all students, nurturing critical thinking, and guiding nurse practitioners' students through their clinical practice has made her a beloved figure in her field. In fact, I just found out today that she writes the exam that every nurse practitioner has to take, or at least writes a part of it. Is that correct, April?
Yes.
So, what makes April's journey even more remarkable is her personal experience with cancer, not once, but twice. About 15 years ago, she faced a cancer diagnosis, which was managed with chemotherapy and surgery. And just last year, she confronted a different cancer diagnosis, which thankfully required only surgical intervention. Her resilience and strength are nothing short of awe-inspiring. In Dr. Bigelow's book, Survivorship: Living Well During and After Cancer, April brings her professional expertise and personal experiences together to offer a guiding light for those navigating the challenging paths of a cancer diagnosis. Today, we'll delve into how her book and her experience can help patients and caregivers gather a supportive team, address the multifaceted needs during a cancer journey, and adjust strategies based on evolving expectations. So, without further ado, let's welcome Dr. April Bigelow to our show. April, it's an honor to have you with us today.
Thanks, Jim.
So tell us a little bit about your background, your education, where you come from. Just tell us about your
Yeah.
life a little bit. I want to get to know you.
Yeah. So originally from Flint, Michigan. So many people have heard of our water there. Came to University of Michigan to do my undergraduate degree. And I started off in biology, actually. I was thinking I wanted to go into cancer research, funny enough. So starting throughout my first, I don't know, 2.5-ish years, I realized I liked that, but I wanted to be able to be more involved with the patients and not just in a lab all day. So I transitioned into nursing and haven't really looked back since. So I came out of my undergraduate and did some, time on the hospital wards like most nurses do,
Yep.
then went back and got my master's and my Ph.D. So I knew I wanted to be able to see patients, but then also teach and be able to do research if I wanted to. So I started teaching and seeing patients kind of as part of that. And then after 15 years as a nurse practitioner, I decided that I wanted to go back and get a little bit more training. So I did a clinical fellowship in hospice and palliative medicine. So I took a year off from teaching, from academics, and I concentrated only on learning again and became a student, which was a little bit of a humbling experience.
We got to some of
Um,
your own medicine.
yes, yes. And then after that, I came back to teaching and was able to integrate that content into the curriculum. And now I see patients for primary care part of the time, for palliative care part of the time, and then most of my time is spent teaching.
So what was your moment in your life when you realized I want to take care of patients? And then what was the moment you realized I want to be a nurse practitioner?
Yeah. So coming from Flint, my age and then also the community, there really wasn't a whole lot of choices. So it wasn't, when you go to college, it was if you go to college. So I knew I wanted to go, but I wasn't sure what I would do. So at the point, like Flint was very disadvantaged. I mean, it still is, but the choices were you be a doctor or a lawyer or a teacher, and that was really it. So I didn't understand what nursing really was, aside from what is shown on TV, which we all know is not accurate. So I had some healthcare experiences with family members who were in the hospital, and I realized, oh, nursing actually is something that I think I would be good at. I would be able to talk with patients. And so then I started looking into that a little bit more. When I was working on the floor, I realized that I felt like I wasn't able to make the decisions that I wanted to, or I had to wait a long time. I would assess the patient. I had an idea about what I felt like would be helpful for them, but then I had to go through too many steps in order to actually
And this was
initiate
when you were an
whatever.
RN, right?
Yes,
Yes.
yes. So then I started going back to school while I was working. So I would work 20 hours a week or so. It ended up being like every other weekend and one shift a week. So I was able to really concentrate on school. And then I knew I would be able to be the boss, so to speak. So be able to have a more active role in my patients' lives and not have to check in with somebody else in order to initiate change or to be helpful for them.
Well, patients and caregivers listening to this probably understand the role, at least a bit of the role of a nurse practitioner versus, registered nurse.
Yeah.
Um, Tell me a bit about your first moment when you realized that you were facing a cancer diagnosis. I want to switch to a very serious topic with you.
Yeah.
Can
So
you describe that, what it felt like, and then what did you do?
Yeah, so I that was a hard time for me because I was checking my own labs and so I was kind of playing my own provider as well, which I don't recommend. It didn't feel stressful to me at all. But I remember I was checking labs and I was being monitored for some potential things. And as soon as my labs started to go up, as opposed to trending down like they had been, I knew that I had some issues. So I actually I sent a page to my doctor and said, I'm not sure if you saw the pathology report along with our elevated labs now. I'd be happy to talk to you about this. And I realized I'm treating myself as if I'm a patient, but I'm talking about myself. I need to make sure that I take a step back now and allow her to take the lead. So that was actually the last week of December. And by the first week of January, I was already seeing the oncology team. And then I started chemotherapy by the end of that week. So it all happened very fast. I think, growing up, I had been, trained, I suppose I'll say, to always kind of prepare for the worst case. So I was already mentally ready for like how I was going to handle things if my labs did start trending up. I don't think that I was mentally ready for like how fast everything happened. That made me feel like, oh gosh, this actually is serious and this is a big
Yeah.
deal. And then my first, I'll say the thing that made it very real for me was my first day in the chemotherapy suite. And the first part of my chemotherapy was intramuscular. So I had to go to the chemotherapy suite, but I didn't have to sit there for hours like many of our patients do. But I had to go and get a shot, and they had just switched over all of their new needle system and whatnot. So everybody was having a hard time with drawing up the
You're
chemotherapy,
a
then
guinea pig.
getting, yes, yes. And
Nice.
so it took a long time. And because of that, I was actually standing. They had me stand for this injection, strangely. And I was standing for a long time. And I think the stress of everything, the fact that I was standing, I'm sure my knees were locked. I ended up passing out during
Oh.
the first chemotherapy. And so I came in the next day for my second treatment and they had me
Oh.
in a bed. And I said,
Yes.
I can tell you've read my chart. I promise that's not going to happen again. But that's when I realized like this is all very serious and I need to make sure that I'm taking good care of myself so this kind of stuff doesn't continue to happen.
Well, your journey there is sounds it's parallel to a cancer, somebody who would be diagnosed. Now, I'm a complete layman here, but my understanding is the patient walks into a room with their healthcare provider and they're sat down and everybody is told that they got the C word, right?
Yeah.
Yours was, sort of in the side door. So
Hmm.
how do you prepare someone and not just say you've got cancer and this is your prognosis? How do you suggest people once they have an intuition, once something's going wrong, how do you prepare them? How should they prepare themselves?
Yeah. So I think that's really important, especially this day and age. So, I I found out myself before I talked to a provider. And
Right.
unfortunately, that does continue to happen now with automated lab results and patient portals. There are some times when a patient will get a result prior to a provider even seeing it because of the way that things are auto released to them. So a lot of the work, in my opinion, should be done beforehand. So when I'm seeing a patient and I'm doing some investigation or ordering diagnostic tests in order to determine what might be the cause of some of their symptoms, I'll talk them through it. Like, these are the things that it could be. This is like easy treatment. This is what I'm worried about. This would be worst case scenario. So they've heard these things beforehand. They know I'm anticipating them. And then even if they can handle it, if I think by looking at them and our interactions, if I think that they can hear and interpret and take in what kind of treatment would be offered, I'll give them some kind of preliminary discussion. So, like thyroid cancer is something that's really
Right.
easy, for example. So, most thyroid cancers, you can just remove the cancer, you monitor labs. They might need a little bit of like radioactive iodine, maybe, but otherwise, we talk in terms of 10-year survival rates. So, I'll talk them through that. So, when they see their labs come back, for example, or their pathology report come back, even if they were hoping it wasn't cancer, then they know we already have a plan and we're thinking about steps forward. There are ways that you can block the results from coming to patients, but it's a lot harder to do than what you would think.
Wow.
So I
Okay.
think, yeah, I think kind of just preparing people beforehand. If I'm investigating something, I always like them to know the things that worry me. But I
So
think that's
during
also, oh, I'm sorry, go ahead.
but during that meeting, what I want to your book focuses on not only the patient but their caregiver. Can
Mhm,
you speak to the role in that meeting specifically of a caregiver? I mean, just basic things. Bring a notebook and pencil.
mhm.
Bring your phone and maybe videotape it. The noise
Yeah.
behind me is my dog, by the way, if you hear
Yeah.
that. But can you speak to the caregivers now?
Yep. I think that's really important. I actually encourage my patients to have whoever would be most important or supportive for them in the meeting. So that means like sometimes we'll have people on FaceTime even, or we will record a session so that way they have it available for their loved ones later. I think that being able to have somebody there to take notes is really important because even if you're getting a good prognosis, once somebody hears the word cancer, their mind goes 1,000 different places. They're
Right.
trying to think about what recovery will be like, what treatment will be like, what does this mean for roles and changes? Can they work? What about their family? So having somebody who's listening to the options, taking notes about, what the next steps might entail. This is all
Even if
really
they're not
important.
present, you're saying doing
Yes.
FaceTime or something.
Yep.
That's a really good one. Okay.
Yeah, that's something that we've been really able to do a lot with. I feel like that made it more acceptable was COVID and being able to feel comfortable having people online. I'll have people Zoom in also for meetings, especially if we're doing like a big family meeting. We have a diagnosis and we're trying to decide what are the best options forward. And we've got kids who live in California and New
Yeah.
York and a couple of local people. So we'll have a whole family meeting where we're able to have everybody present and have a voice and be able to ask
But
questions.
you welcome that, right? So you
Yes,
encourage people to say,
absolutely.
okay,
Absolutely. If you have a provider who says, no, no, I don't want to have, extra people in the room, to me, that's a red flag and a concern because if you have somebody who's there by themselves and you're limiting their support system, you're just making it a little bit harder than it even has to be for the patient. It's hard
yeah,
enough already. Yeah.
yeah.
So I think providers also, if they're prepared, like I sometimes will have things written out for my patients beforehand, or I'll tell them, like I had patients yesterday that I said, this is a whole lot that we're talking about right now. So, just listen. But when you go home, there's going to be a message in your portal and it's going to outline everything that we talked about. So that way you have it, you can think about it, talk with other family members who couldn't be here today. And that's a little bit extra work on the provider, but I think that it's worth it. So that way your patients are informed and can feel comfortable.
Okay. That's really good. Thank you. That I'm sure that'll be valuable both for the caregiver and the patient. With your experience in, seeing people who have, you mentioned thyroid, but there are far more serious cancers. And
Yeah.
can you speak, let's go right to the more serious patient, right? And the
Mhm.
question is, um, with evolving and changing expectations or the diseases changing over
Mhm.
time, can you speak to to your role and your role, and then also let's speak to what the patient needs to understand and the caregiver.
Yeah. So there's with the evolution of kind of how cancer treatment has come about over the years, we've been able to identify maybe some genes so we can do like gene specific targeted therapy. Whereas, 25 years ago, we would just have to give these big chemotherapies that would kind of kill all kinds of
Yeah,
cells.
nuke
Now
it.
yeah, we can target things and that's really nice. But then there are still some things where you'll get a diagnosis where, um, we don't have any good steps forward. So we'll say, we have this big chemotherapy that we're going to give you. We're going to hope for the best, but we worry that it's going to, not give us the good outcomes that we want. So sometimes we'll talk about doing time limited trials. So we'll try a chemotherapy for a certain amount of time that we agree upon with the patient in order to see what kind of response they have.
Yeah,
Because it's really a balance between quality of life and adding quantity of days. So, we're trying to just help our patients live as well as they can for as long as they can. But, it doesn't mean anything if we're extending their time here by a couple of months if they're in the hospital those months and they're not able to interact with their friends or loved ones or do things that are enjoyable to them. So,
yeah.
really kind of getting to know your patients at the beginning and making sure for our patients and our caregivers, like making sure that their providers understand what's important to them and what is meaningful to them. So that way, when decisions come, your providers can help think through. So, Jim, based on what I know about you, like I know that we talked about doing XYZ was really important to you. And I worry that if we continue on this line of treatment, that's not going to be the
Can you
case
give
for
an
you
example
anymore.
of that? Like an example
Yeah.
in the more advanced patient.
Yeah, so I had a patient who I just recently had seen who had a short prognosis that was offered to him for a metastatic prostate cancer that he had, and he originally had decided that he wanted to be able to have aggressive treatment, which was a reasonable option, but he didn't anticipate, I guess, how bad he would feel during
Oh,
that treatment. And we're talking, it was going to extend his life by maybe a month or two. So after he started treatment, he was only a few weeks into it, and he decided that he really didn't want to do that. So we got to have a conversation with his oncologist and him about moving forward and how it wasn't giving up. A lot of people feel like they're giving up if they
yeah.
decide not to pursue disease active therapy. But it's really kind of pursuing a different line of treatment, which is comfort focused, which is completely acceptable.
So what's the role of the caregiver here?
So the caregiver is to make sure that they are supporting the patient as much as possible. So everybody thinks like, oh, I need to make sure that I'm, bathing them or helping them with their medications or feeding them. And that's important, but then also still helping them feel like themselves. So I have patients who were marathon runners and now they have a cancer diagnosis. So, like, the main thing that their caregivers do is help them get out and walk every day. So they're still able to
Yeah,
move, for example, or to help them engage in things that are meaningful. So, if they can't get up and move to get some of their craft supplies or quilting supplies or whatnot, you can help them do that. Sometimes it's really organizing a bunch of well-meaning friends and family that really want to all come and see people at one time, but during treatment fatigue is very real and can sometimes be overwhelming for patients. So caregivers will need to almost be a gatekeeper and
yeah. Be a
protect the
blocker, right?
patient.
Right.
Yeah, yeah, and just make sure that things aren't being thrust upon the patient in ways that are just making things worse. So they need to create a little protective environment for them that can help them feel like themselves, like they're not just a cancer patient, like they're still themselves. And
Yeah.
then also put them in a position where they can have quality of life and recovery if that's the route that they're going, and just be as healthy as what they can be.
Yeah, I remember you mentioned one story of a gentleman who just wanted to watch the Lions.
Yeah.
Can you speak to that, the Detroit
Yeah.
Lions?
Yes. So this is one of the reasons that I love to get to know people before, or like as early in their diagnosis as possible. So we were having a conversation, and he said, April, I just feel like quality for me, like I know I have a quality of life when I can sit on the couch and watch the Lions and I can eat
So
chocolate
great.
ice cream. Yeah, he was like,
Yeah,
the chocolate ice cream was key. So
yeah.
he had esophageal cancer. So when it got to a point where they were talking about whether or not he was going to have a feeding tube or not, it was easy for him. He's like, I already told you, like, I know quality for me is being able to eat the chocolate ice cream while I'm watching the Lions.
Yeah.
So we
That's
were
celebrating a
able.
small victory and feeling
Yeah.
alive.
Yes,
And
exactly,
yeah,
exactly. And there's like times when patients will feel like, for this gentleman, for example, if you get a feeding tube, like, oh, I can't have any more chocolate ice cream because I run the risk of choking or aspirating.
yeah.
But you can do little things kind of in between too. So this gentleman, he ultimately did decide to do a feeding tube, but that was because he knew that he could have a couple of bites of ice cream like while he was watching the Lions, and he was
Oh,
willing
that's
to
so
take the
sweet.
chance. Yeah. So that way, like, he knew that it was a risk for him, but
Yeah.
he was willing to take that in order to be able to have what he considered to be quality of life.
Oh, that's so great.
Yeah.
Thank you for sharing those stories. And I want to talk about the book a little bit, and then we'll wrap up. The book is an updated support for patients and for their caregivers. Can you speak to the reason why did you want to do a book like this? What does it mean for you personally? What are your hopes? And what do you hope this book accomplishes?
Yeah, I think that when people get a cancer diagnosis, they're really focused on what is treatment going to look like and what are side effects going to look like. And that those are important things, but there are some diagnoses and some treatment regimens that last a long time, and people don't necessarily feel like they know what to do. Like, what can they do? They can't administer their own chemo. They know they have to try to stay healthy, but they don't know what that means or what are the steps that they can do to make that happen. So I wanted to be able to provide a resource for not only the patients but their caregivers, and what are the little steps that they can take in order to try to be as healthy as possible, not only during treatment, but afterward. Because once you've kind of moved past treatment, if you have a cancer that, you move into remission, nobody really you fall by the wayside. You don't really have the same type of supports that you have when you're going through active treatment. So, what kind of things do you have to do? And a lot of those things are the things that in the back of your head, and you hear them your entire life, but having them outlined in a way that's like manageable for patients and the family members, I think, is important. So I just wanted to make some resource for them.
And was there a particular patient story in the book that you wanted to talk about that you thought was inspiring and it would be helpful for the people watching this podcast?
I think all of them are, and really kind of drive home the point that, and they're all real patients with the names changed, just to see that they're not alone, right? So everybody who gets a cancer diagnosis kind of has battles and questions and concerns that they go through. Like, how do they stay healthy? How do they actually continue to be physically active? What if they're too tired to do that? How do they take those steps? And then also providing ideas that they might not have thought about. So, people who grow up in the United States don't tend to think about complementary therapies as much, for
Right.
example. So, knowing that those exist and kind of getting an idea of how they may have helped another patient in real life, I think is really a goal of kind of sharing some of those patient stories. And I think there are many in there that patients and their caregivers would find helpful, just to know that they're not alone.
Oh, that's really good. 'Cause I think in our deepest, darkest moments of facing a cancer diagnosis, of which you faced two occasions,
Yeah.
um, you need to know you're not alone and you
Hmm.
need people with you. So Dr.
Absolutely.
Bigelow, April, thank you so much. I really enjoyed spending the time with you. And if people need to reach you, is that acceptable for them to
Yeah.
email you?
Yep, absolutely, absolutely. So they could email me at my University of Michigan account. It's on the website. It's A Ballard, Ballard at umich.edu.
Wonderful. Thank you very much. And
Thank you.
to the caregivers and patients, we hope you enjoy her book. And we thank you very much. April, thank you so much.
Thank you.